This is the start of medical emergencies. It's quite a large module. It's going to cover a little bit of Chapter 7, Chapter 9, 10, 11, and 12, and then that'll be your next module exam. So what I'm going to do is kind of break these up into respiratory, cardiac, altered mental, allergies, poisons, drugs, environmental, and behavioral. So this one's going to be nice and short. It's just going to be an overview of medical emergencies and kind of what we need to know from it. So all of your calls are going to be broken up in between it's a medical call or it's a trauma call. Not saying that some of them can't be both. Sometimes people have, they become faint, low blood pressure or low blood sugar, and they faint, and then on the way, to hit the ground, whatever that might be, they experience trauma. They hit their head or something like that. But so in medicine, we're going to recognize and manage life threats based on assessment findings of a patient with a medical emergency. And this is going to prepare us for what to do in the first few minutes while we're waiting for additional emergency response. As we talk about a medical overview, we want to talk about medical complaints. So they could be something like a neurological problem having to do with the brain or the spinal cord or something like that. So they often present with a decreased level of consciousness. So you may get a call for a person not acting right, or for a seizure or a possible stroke. They're telling you that this is it, but it's not necessarily a field impression or a diagnosis. It's just kind of what the family or the bystander thinks that it could be. So it could be anything, but it gives you a little bit of information. It could be an abdominal disorder. It could be somebody that just has abdominal pain, or maybe they have upper gastrointestinal bleeding from the mouth or lower gastrointestinal bleeding from the rectum. So especially if they tell you that information, then you know something more about it. It could be associated with the endocrine system, like diabetes. And diabetes typically presents with two different types of problems. Either it's high blood sugar or low blood sugar, and either one of these can cause altered mental status. It could be cardiovascular in nature. It could be somebody that has chest pain. And any chest pain is a heart attack until proven otherwise. We treat every chest pain just like a heart attack. It could be cardiac arrest. Person's not breathing, they're not moving, and there is no pulse, and it's probably from a cardiac event. It could be a respiratory problem. And when we look at these, we manage upper respiratory problems differently than we manage lower respiratory problems. So it could be associated with upper or lower airway. It could be a genitourinary or a renal problem. So renal, we think of kidneys. And some people, maybe they have poorly controlled diabetes, poorly controlled blood pressure, and their kidneys take the toll of all the vital organs. And the vital organs, the four of those being the brain, the heart, the lungs, and the kidneys, of all of those, the kidneys are the first to fail. And once the kidneys fail, then it kind of is cataclysmic for the rest of the body. And the only temporary fix for this is hemodialysis, so we'll look at those. So we talk about common medical conditions, could include any of these. And when we look at these kind of things and we think about maybe in our own family some medical history that they present with, knowing their history can oftentimes tell us a lot more information than just, oh, I think it's a heart attack. If they have had a heart attack in the past, they're more likely to have another one. So, and most of those people are quite experts at it by then. They can tell you this is what it felt like last time. People that have dyspnea, which is a medical word for difficulty breathing. DYS means difficulty, and PNAEA means breathing. That could include asthma, especially if they've had an asthma attack before. They come readily available with their own inhaler. Stroke is a clot that affects the blood flow to the brain. It could also be a bleed, but more often so a clot. And, those present with specific signs and symptoms that make us think that. People with diabetes. So I like this little picture here. It shows all the sugar molecules, the white or the glucose, in here. And you say, well, why would somebody have high blood sugar, but they're still not acting right? Why would it affect their mental status and maybe even cause them to go into a coma? Well, all that sugar gets trapped in the bloodstream. It can't cross that membrane of the cell or the wall of the vessel because it needs a helper protein called insulin. So people that lack insulin, that sugar stays in the bloodstream and it doesn't get to the target organs where it needs to be. So as an EMR, you can prepare yourself for some medical patients by studying sometimes the risk factors, sometimes the onset, and then definitely signs and symptoms and treatment of each condition. When we talk about all of these, we want to keep in mind that patient assessment of medical emergencies, going into that scene size of when you get that call from dispatch and they say it's a possible heart attack. You're like, wow, I'm first responding, I'm going by myself. What kind of resources do I have with me? What kind of supplies do I have with me? And definitely, how far out is that backup unit? You know, do I have an AED if it's worst case scenario? To get in there and do that primary assessment, that AVPU ABCs, their level of consciousness, and are they breathing? Do they have a pulse? Just sometimes by being there with somebody, that EMR, the first responder, just gives everybody in that household, especially the patient, that sense that it's okay, they're not going to let me die. Well, that may or may not be the case, but some people, you know, if they're going to have a cardiac event, they're going to have a cardiac event. It doesn't matter if it's an EMR there or a physician, but it gives them that sense of it's okay, they're here now. But getting that history, getting the sample history ahead of time and providing any care that you can before that ambulance gets there is a big part of taking care of a medical emergency. So when you're en route, review that dispatch information, assess the scene, always look for safety issues. You know, we're going to get into trauma, we're going to be looking at explosions and fires and falls and unstable environments. But, you know, the little chihuahua that comes running around from the bedroom, you know, that's your safety in there. So think about that. As you perform that primary assessment, try to form an impression of what the problem is. And don't put blinders on of the dispatcher told you it's a heart attack, so that must be what it is. You know, it could be a lot of different things. So you're gathering information, gathering assessment findings from the patient to determine the best that you can. If this problem is a priority, number one, relay that information. And then, excuse me, if there's anything that you can do to make it better before that ambulance arrives. So a big thing in doing that is positioning. I mean, you don't know how important it is to think about what position you find the patient in. And everybody's like, oh, don't move the patient, don't move the patient. Sometimes you do. So if you walk in, the patient's having difficulty breathing and they're laying down, a better position for somebody who's having trouble breathing is sitting upright. Put pillows behind them. How many pillows they use at night can be a clue as to their problem. A lot of people that have chronic congestive heart failure will sleep in a recliner. Not that they recline, they just raise their legs up and they sleep sitting up. Or they'll tell you, I sleep with 6 pillows. 6 is kind of excessive, right? They tell you, I can't lay down or I'll drown in my own fluid. If somebody says, oh, I feel like I'm going to faint, I feel like I'm going to faint, well, don't just let them, you know, go timber. Lay them down, preferably on their left side. You know, at a very minimum, sit them down so that, you know, they feel better. Let them put their head between their knees if they're sitting. If they feel nauseated, you know, sit them up a little bit and get them a bucket. If somebody says, I feel like I'm going to throw up, you have 2, 1 to throw up, you know, 0, and they're up-chucking. So, you know, get them something rather than, you know, they're looking for a place to throw up. If they feel hot, don't cover them up. You know, we'll talk about covering the patient to keep them warm. Well, if it's 104 outside and they have a fever, don't cover them up. You know, uncover them. If it's chest pain, think of chest pain like this. They have an injured heart, and their heart has to pump the blood around to all parts of their body all the time. It never stops. So it's kind of like if somebody had a broken ankle. You wouldn't want them to walk on that broken ankle. Well, don't let them walk on that broken heart. And by that I mean the more exertion that they do, the worse that chest pain is going to be. So no matter what, let them sit down, lay down, whatever's more comfortable, usually sitting down, and don't let them move around. If they say, I live alone, I need to put the dogs out and bring the cats in, I need to turn off the light in my bathroom, ma'am, I will do that for you. I just need you to sit still and as much as you can, relax. So it's best to get that medical history on patients before you perform that secondary assessment. And here's why. if I'm doing the sample, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events, and let's say I jump in there and take a set of vital signs, and the blood pressure is like 180/100, pretty high. And then I take my stethoscope out of my ears and I look at the patient. I go, "Ma'am, do you have a history of high blood pressure?" They're going to look at me like, "Why is it high?" Whereas if I got that information in the sample, I would have already known that. I'm not going to stop at like 120/70. I'm going to expect it to be high. She told me she has a history of high blood pressure. So that's important information to find out before I start doing anything else. Reassuring the patient, "Ma'am, the ambulance is on their way. I know it seems like a long time. They gave me an estimated time of getting here in 5 minutes, and we've got a lot of information I need to get from you before then." So, all that stuff that you can do before the ambulance gets there is so much appreciated. They bring in the stretcher, you hand off that communication, hopefully it's in writing too, and it saves a whole lot of time in doing that. So something else to kind of throw out, and you don't necessarily have to learn it in this order, but in the sample, in the S, the signs and symptoms, a sign is something that you can see, hear, smell, or touch on your patient. Don't lick your patients. Okay, that's the only sense we're not going to use. But a symptom is something they tell you, like chest pain. So especially when you hear the word pain, this little acronym OPQRST can take that information of pain and go a little bit further. So if they say I have chest pain, well, I want to know what they were doing at the time of onset. And it does make a difference whether they're watching TV or out mowing the yard. Were you mowing your yard and then when you rested, the pain went away, and then your daughter came out and she argued with you and the pain came back? Is it brought on by something like angina is? Is there anything that makes it better or worse? And we call that provocation. When I sit down, the pain is less, but when I get up and walk around, it's more of the quality. And so in patient assessment, we talked about open-ended questions like, well, does it feel like a knife going through your chest? Does it feel like pressure? Those are closed-ended questions where they only answer with yes or a no. And a better way to ask that, to describe the pain, is just that. Can you describe the pain for me? And we're assessing quality. Oh, it feels like an elephant sitting on my chest and it's really tight. Well, then I want to know, is it right there in the center of the chest, or does it move around? So if it moves, where does it move to? I want to see if that pain radiates. Yeah, it moves down my left arm. My left arm feels numb. It feels weird. On a scale of 1 to 10, 10 being the worst pain you've ever had, how would you rate this pain? And it's good to get a baseline with that, because I guarantee you, you show up on scene, somebody's having chest pain, 10 of 10 chest pain radiating down their left arm. It's worse when they walk around. They weren't doing anything. They were watching TV. And then you say, well, I'm going to put you on a little bit of oxygen. I'm here with you now. After a few minutes, what is your pain now? I guarantee they're all going to say an 8. It's going to go down, not because the pain was any less, but because you're there. You're just making them feel better, just reassuring that they're in good hands. And so it's good to get that baseline, and then some of the other things that EMS will do, then they can tell, if it's getting better, can we get it down to a 2 or a 4 or something like that. Biggest one here is, what time did it start? Don't assume that people have things happen and then they pick up the phone and call 911. If this is a typical 65-year-old male, he's going to smoke another cigarette, talk himself out of it being chest pain, maybe take some Tums because he's almost convinced himself it's heartburn. And it's going to be a couple of hours before he calls you. So you want to know when this first started. And that's a neat little acronym. We really emphasize this in the EMT portion. It's just a nice way to find out more information about that, signs and symptoms. We want to find out about general medical conditions. So here's something really neat. People that have medical conditions, a lot of them will have like a medic alert bracelet or a necklace or something like that. Identifies them as a diabetic or a dialysis patient. Sometimes you can tell by the shunts in their arm. But we can all, if you have a smartphone, you can, and I know on the iPhones it's a little white heart with a red heart in the middle of it. I think that's what it looks like. Let me check real quick by looking at mine. As I say that, I second guess myself. Isn't that funny? So it's like a little white square on one of your apps, and it has a red heart in the middle of it, and it said health. If you touch that, When you go to the medical ID on the right, if you don't have an iPhone, the Androids have it too. I'll just have to look up that information for you. But that little information on the right, you start putting in that. It's going to ask your name, date of birth, medical conditions, any medical notes, allergies, and what those reactions are, medications, who your spouse is, contact information, children, blood type, whether or not you're an organ donor, weight and height. I usually lie on mine. But at any rate, why this is good is if you're unable to answer questions for me and your phone is handy, I can open that app without even knowing your passcode. And if you live alone and I need to call those are your contacts. So I can hit one of those numbers, and again, not knowing your access code to get into your phone, I can contact a spouse or a child or a parent and say, hey, I'm here at this residence with I think this is so-and-so, and get more information. So most people are doing that now just for that very reason. So that's going to wrap up our intro part of this. We're going to continue on with altered mental status and the things that kind of fall in with that.